we decided this year in the General Assembly to give this a different sort of priority and create a permanent behavioral health commission. So today, the plan is, and the membership of the two groups is different, is somewhat different. And so some of the members who have been on the SJ 147 commission or joint subcommittee are not here, and we might not have a quorum. And if we don't, we'll have to reconvene that group during the special session to make some recommendations, because we have some things, we have serious discussion today. We also have a serious crisis in our hospital system, and I'm glad Commissioner Land's here so we can address that. You know, there was an editorial in the Norfolk paper this morning. I use the word Norfolk a little lightly because I think it's actually published in Newport News now. There was an editorial in the Norfolk paper this morning that said the General Assembly hasn't had the right priority for mental health over the long haul, even though we've made a lot of noise over the last several years, and that's, you know, sadly true. I've done some things, and I'm proud of the things we've done, but we haven't done enough. We just haven't done enough. That changes today. We've got to commit ourselves to getting some things done that are going to make a difference, both in the special session and then the next General Assembly session, and on an ongoing basis. We're gonna expect more. We're going to demand more, and we're going to do more. Let's begin by having Delegate Watts and Senator Hanger. So we're up to 6. So one more and we'll have a quorum. That's great. We're going to start with a presentation from the Department of Behavioral Health. Commissioner Land, welcome. I want to point out that we're going to convene the new commission at 2:30 across the way, and that meeting's primarily going to be organizational, to figure out what we do with the commission, how we're organized, and how we're going to go about hiring a director and go forward with a work plan. But the substance, I hope we can discuss in this meeting. Thank you, Commissioner Land.
How's that? Better? Oh, yes, much better. So again, good afternoon, Chairman Deeds and members of the committee, and thanks for inviting me to present to you today. Mary Ann, next slide. I'm going to be focusing on these two agenda items today, updating you on the state hospital bed census crisis. And as all of you know, that on last Friday, I did need to have to take the action of closing 5 of our adult and geriatric facilities to admissions temporarily because of the unsafe staffing levels and the amount of serious injuries and incidents that were occurring in our facilities. So I'll be giving you an update on that. And then second, I'll be doing an overview of our ARPA funding requests, which I hope will be supported and hope that will be truly transformational for our system of care here in Virginia. And I'm going to take have a slide in the deck that gives us kind of a transition slide between these two, and take questions then. But if you have questions throughout the presentation, please feel free to ask.
Yes, ma'am. I want to point out that I don't know if the members have the information from our June 15 meeting, but the census numbers are actually lower than they were on June 15. Mm-hmm. And so I guess that speaks to the closure, mm-hmm. or the closure of admissions relates mm-hmm. to the loss of employees more right. than anything else mm-hmm. right now.
Yes, and the injuries.
Okay.
Mm-hmm. Yes. Kind of what's happened is that our safety net is no longer safe. And so that's why I took that action. So next, we can actually go 2 slides, the next one, to talk about first the bed census and utilization. So like you said, we were still having high levels of census in our facilities. This was the snapshot the day before we closed. We have had in those 5 hospitals 82 discharges since that time, so we are moving to move to that safer level. I'm not expecting that we will get to perfect staffing, what a staffing grid that says 1 to 6, 1 to 8. I'm not trying to get there. We just need it safer. And so I want to minimize the number of days or weeks that we have to have this closure, but it's got to get safer. And so that, again, shows you kind of where we're at, very high and dangerous levels of census. And the next slide, we're going to talk about where we're at with the staffing levels. So our vacancies, of course, remain, as you see in the table, above 20%, and in some up to 53% in our facilities. Our direct care compensation falls way below market value. We are currently sitting at or below the 10th percentile for a market compensation for our direct care staff. We started just in March before the pandemic. This is not a new issue. We had 1,000 state facility vacancies going into the pandemic. These shortages have been exacerbated by the pandemic, and now I got the updated numbers to this. We're this morning at 1,620 vacancies. So we have continued to see resignations are accelerating. We also, of course, just as a reminder, are funded to operate at 90% staffing. But now we are as low as 60 to 70 in some facilities, and CCCA itself is at 35% of staffing, which is, we'll talk about that and where they're at with their beds later in the presentation. Our hospitals had been operating at 100%. The three that are still open, Northern Virginia, Southern Virginia, and Southwest Virginia, are at 100% these days because they're accepting diversions from across the state. They too have staffing shortages, so we are keeping an eye on that because if they start to lose staff and start to see those levels of injury, we'll have to take an action there as well. So we are really challenged, and I also wanted to report that we've had 80 serious injuries now since the July 1st. We had an additional 17 on Monday and Tuesday of this week, so instead of being in that 4 to 8 range, we're now in the 8.5, range, and so we're still seeing those challenges.
Well, Commissioner, and any injuries, as I understand, any injury is a serious injury, I guess. But how are you defining that?
We're doing these are serious injuries and incidents with lacerations. We've had orbital fractures, assaults with lots of hematomas and abrasions and broken bones.
And these are assaults of patients on
and
patients
staff.
and patients on staff.
It's combined, yes, sir. Yeah. We've also been having issues with the contract staffing. So we have, over time, worked to, offset some of our staffing challenges with international nurses, contract staff for clinical staff, whether that's RNs, LPNs, DSAs. We've done locum tenens physicians and other providers and those types of things. What we're seeing is that we're also losing the contract staff. And so that support and that level is also being lost to us. So we're seeing them. So some of those 17 that some of those other additional staff that left Monday and Tuesday that increased us up from what I reported in my letter last week were contract staff. So it was like 5. We lost 5 more contract staff on Monday and Tuesday. So it's not just our state staff employees, full-time employees, it's our contract staff. And if we cannot get that, and they're either leaving before their contracts are up, or they're not re-upping their contracts, and our partners here that we've been working with, the providers that have the staff and do the contracts with us, are saying that they have scraped the bottom of the barrel and they cannot find anybody else willing to work in our facilities. So we are going to have to go out of state, which is going to make it even more tremendously expensive to find contract staff to come in to help support this. So one of the things that we're doing right now is we're taking our $25 million reserve fund that we have and are allowed to have for emergencies and unexpected emergencies in our facilities, and the emergency is now. And so we are going to spend that. We are having employee direct care staff bonuses that we hope to be able to have them in the August 1st check, and it will be, there are things that you have to do through DHRM if you're going to give a bonus in excess of certain amounts, and they have to sign saying that they will stay on for a certain amount of time, and it's really to help stop the exodus. But they have to sign that paper. We're going to have everything keyed and ready for them. If we can get the signatures for the staff, we will deliver the checks by August 1st. That is going to cost us $14.6 million. And then the rest of that $25 million, that $10.4 million, we're going to use for contracting out-of-state contract staff to come in to support these 5 hospitals so that we can deliver the care safer and get the discharges accelerated. And so I believe that we'll have both our signature and the company's signature today, and they feel like that they can deliver 196 direct care staff, which are 30 RNs, 36 LPNs, and 130 DSAs. And we will put those into those facilities to help support and do the care for those patients so we can get back to normal operations. But we will have to, that will give us the ability to quicker reopen the door. That's only for 13 weeks though. And so in the meantime, we're going to need to be finding, so some of our requests for the ARPA funds that you'll see later in the presentation are going to be to get additional funding we would love to be able to bring them up to market rates so that we can attract people to come instead of just keeping our current staff in place with bonuses.
And you're going to share with us how much it would take to get
Yes,
up to
sir.
market rates?
Yes. Okay, so next slide. Okay, so I talked about CCCA and on June 30th, we closed last year after an outbreak of COVID, and when we at VDH's requirement, and when we reopened, we had lost down to about 35% staff. And so we weren't able to reopen. So the census went way down because we had the quarantine periods and we worked the patients out during the closure. So when we opened, we had very few patients still in the building. We had not been allowed to admit because of the outbreak. So we were able to manage those patients, but then we quickly started refilling. And it got to a point where we had to say we can't take any more patients. And that we finally got to about 30 beds open. And then we've significantly started losing more staff because of the dangerousness on the units. And so that has accelerated. And on June 30th, we actually had to reduce capacity by down to 18. So we're at 18 beds. So we have 30 beds closed.
Commissioner Land, I live, I guess, one county over from Augusta County where Stanton Hospital CCCA is. A lot of nurses have contacted me over the years, and they've talked about over the last year or two, and they've talked about the mandatory overtime. Do you think policies like that maybe have pushed people away as well?
Oh, that's definitely true. It's the mandatory overtime and the lack of safety. We are doing exit interviews on every single person who's resigning, and it's all correlating to those two issues.
You've only got 48 beds there, and we ask, that you work with the hospital here in Richmond, the VTC, and also KD King Salter's the new hospital. Are the agreements you're working out with them going to get them to take some of the tough cases?
Right. So when we worked with CHKD, we made it. Hi. Sorry. Welcome. With CHKD, we went through a work group process and had a report that we submitted that is around what their type of patients that they're going to take. And so they're going to have a 60-bed facility in a new tower, if you will. They call it a bed tower. And they're also going to be adding 6 to 8 beds in their current medical facility, so the Med-Surg hospital, that will take a medically complex patient that has co-occurring psychiatric issues, but they're also going to do what we call psych med in the psychiatric area in the new building. They will be able to manage medically complex patients that are there primarily for psychiatric issues. So that's one of the main populations that we need. They're also focusing on a 12 and under group of patients, and they're going to have bed space for intellectual and developmental disabilities patients, which is another one of those areas that we really need focus on. In the meantime, they have done one of the inpatient pilots that were funded. We've done one with them, and they are building out, I think it's 6 to 8 beds contiguous to their ED. that's separated and is staffed with behaviorally trained staff. So it will be almost like an observation unit, but they'll get actual treatment started. And they have been very successful in recruiting psychiatrists for their new program. And they have developed a bridge clinic in that psychiatry practice that also has therapists and all. So they're able to do a clinic to bridge them once they come out of that more observation type unit that can be, 23 hours to 72 hours, so that they then are stable enough to then go to the bridge clinic until they can get into long-term services for the patients wherever they're at in the Commonwealth. And so I think that CHKD is being a great partner. We have also been working with VTCC. They've got a new Dr. Feinblank that's that's the chair of their psychiatry department. He also took over as the medical director and had ownership of VTCC, and really was working to see why weren't they able to take these patients, and found that the culture, I believe, just did not support those types of patients. And so he has really been making leadership changes and staffing changes and programming changes so that they can manage those patients. And so they're still rebuilding their staff from that. And then too, they've put in a new program. I'll just tell a little bit about it because I don't know all the details, but it's more like a care coordination case management program within their ED, and really working with the families and the patients to see if there's any other level of care instead of inpatient in a locked facility that we can do services for. Are there safety plans that we can put in place and make them able to manage and be successful in a community service as opposed to an inpatient setting? So those two are working really well. And we also are working through a same process with Chesapeake Regional around what is that, what population are they going to address for us? And so we'll be sharing that with you as soon as we get to the finish line. So thanks. Let's see. Next slide, please. So this is a slide I just wanted to make sure. I know that there have been a lot of questions, and so I wanted to put this in here. We've talked already about most of this, but I wanted it just to be really clear that no existing patients will be discharged in an unsafe manner. We are not saying we're just going to send patients out to get the census down. Everybody will be receiving a very safe and comprehensive discharge plan. We're working closely with all of our partners in the community to make sure and that any and all alternatives to step down patients into either continuing inpatient care or appropriate transition and step down services are available. And so just wanted to make sure, make that pretty clear. We are monitoring those staffing levels at those other facilities, which again are northern, southern, and southwestern. Let's see. Once our census comes closer in line, and again, it doesn't have to be perfect staffing, but it just has to be safer, we will go ahead and start and open up to, if we discharge 3, we'll take 3. Just like we did after the hospital, with the hospital closures due to the outbreaks. We didn't say you can't come, it was delayed. And so as we're able to accept a patient, whether it's in one of the 3 that are still open, or once we're able to get to a safer level, we'll start doing that. And then as staffing improves, we'll be able to incrementally just add back the beds so it stays safe. And so I just wanted to make sure that that's really clear. But we all also are calling on our community hospitals to offer any available private beds. We've sent out and asked again for contracts to go ahead and take these patients. I know it's a burden on them. These are our most challenging patients in the Commonwealth, and I understand their risk aversion to inviting them, to bringing them into their facilities where they're going to injure their staff and their other patients and tear up their facilities. I get it. But it's not as good to have them in the ED, boarding in the ED, particularly if a hospital does not have psychiatry consult service that can actually begin treatment in the ED. So we're asking for any and all availability to be opened, and also for step down. Are there CSUs that have availability? Or, all of the residential programs, our long-term care providers. We have patients who've been days, months, weeks, years, that are been ready for discharge, that are sitting in our hospitals needing 24/7 care. And if we could get those out, we would not have a crisis, probably would not have a crisis.
And I appreciate that, Commissioner Land. Longer term, it seemed to me that if you keep people out of crisis,
Right.
they stay away from the hospitals.
Yes.
Okay, so that requires us to have a good relationship with our community providers, our
Right.
CSPs. What are you doing, or is anything going on now to kind of make sure that we've got such a disparate network of providers?
Right.
What are we doing to make sure that we can keep people out of crisis in the first place through the CSPs?
So, we have a number of initiatives, and we've asked for funding to accelerate things like STEP Virginia. We have this crisis transformation. I know that there have been funding requests over time that we've, either we were delayed by a year because of COVID, or we were anticipating doing it in the 23-24 biennium. We're asking with this transformational funding opportunity to really do that transformation and build those services in the community. Go ahead and do it. We have not done it to scale. We have not done it to where you can really see an impact. And it's so slow. You're doing great work, but it's not, we need to get the services in place. And so we are going to add, that is one of our asks that you'll see later on a different slide, but it's those types of things. And I think that the mobile crisis and the crisis call center and the Marcus Alert and working together in that crisis continuum and making it truly comprehensive is really going to be a game changer for us as well. So,
Mr. Chairman.
Senator Mason.
Thank you, Mr. Chairman. Commissioner, so although we said we've closed, are we still accepting forensic TDOs to these facilities this week?
yes.
Mr. Chairman, so we're really not closed. And I guess the real question there is, how did we decide? How did we decide to continue to accept the forensics, but stated in the code, versus not accept the civil stated in the code? How did we decide which portion of the law to enforce and which portion of the law to suspend?
Yeah. So I think that one of the things that I looked at was we were able to change in the last couple of years, like to have a 10-day, up to 10 days to get them admitted. What we were seeing before is that we had huge numbers delayed, and we did not want to take that concerning thing on as well if we could get the relief we needed with doing the civil admissions being closed in those facilities, because we have hospitals in the community with bed space that can take the civils. They're not going to be able to take the forensic.
Mr. Chairman.
Senator Mason.
And I'll stop. But those hospitals have the same resource constraints that we do, right? And Senator D just made a good point about the disparate levels of care in CSBs across the state, which admirably STEP Virginia is trying to attack. What kind of communication have you had with the CSBs about this decision? And what support have you given them this week? Because if we're not accepting civil, we've still got a bunch of people sitting in emergency rooms this week. The CSBs are still required. They can't suspend. They're required to go there, assess, treat, try to continue to find a bed. What help or guidance have we given them this week during what must be a frightening time for them?
Yeah. I really don't know how to answer your question other than that we have been communicating that we have these issues over and over and over again, and it's not the CSB staff that are getting these injuries. They are not, I don't know that they mandate overtime, but they are not being mandated to work, 3/16s and 2/12s every week and not being able to see their families. And being face-to-face, which a lot of the Community Services Board's activities that are face-to-face have gone virtual. You can't do that in a hospital setting. So I had to make the decision that was best for the people that are under my care and my responsibility to take care of in our facilities. It cannot be that we have this level of injury and the lack of that. It's so hard to give even therapeutic treatment and have a therapeutic environment at this level of staffing, it's very difficult to provide the care that would stabilize these patients, which just means that they're there against their will and not progressing in their treatment. So that's what I would say.
Commissioner Land, it just distresses me in the last, I remember visiting the Northern Virginia Institute of Mental Health a couple years ago. I've been to Central State a number of times over the years, and every time I've been, employees say the police department is called here every day. And this has been going on for years. There have been assaults for years. And they're that much worse now. I mean, I guess combined with the lack of employees.
It gets more dangerous.
Yeah.
I mean, just being at 100% or almost 100% makes it unsafe.
Delegate Bell, you had something?
It's not quite on point.
Oh, well, I think Delegate Hope has something.
Thank you, Mr. Chairman. Thank you, Commissioner Land. I appreciate you coming here and talking about this. I'm trying to understand the process to coming this decision. You've come to us many times, and to your credit, you've been pointing this out to us. But the decision to close admissions was a surprise to me. And can you walk through the decision-making process? Did this first come up as an option a month ago, a year ago? And I mean, did you check with your counsel? Because I thought at first when I read it, I said, I don't know how she's authorized to do such a thing. How can the department do that? And then, of course, I thought about what you had said to us in the past and how serious, clearly, the issue is there. So can you walk me through that decision-making process? At what point did you discuss this with your team about it being a possibility, and did it go through legal? And you know, I'm trying to figure out if this would ever happen again.
This was not an approved decision. I did not have approval from HHR or the governor or our legal. This was a decision that had to be made because of the safety issues in our hospitals. You know, we cannot operate like that. If any facility that we license operated like this, we would close them down immediately. Yep.
Price?
Yes, thank you, Mr. Chairman. I guess I kind of want to get to solutions, and I know that you're headed that way. But I did want to see when you're talking about the exit interviews, and in your July 9th letter, it says, just as you've said today, that there's direct correlation to work hours mandated and lack of safety, which immediately seems like if you had more people, then it would be better. But what are some of the other things that were on the exit interview? Because what I'm hearing is it's morale, you know, like all of the other things that come around for that. So how do we attract people into something that everyone is fleeing if the answer is more people?
So, but we also are not compensating at an appropriate level. And if you can't recruit to add in more staff, nobody in this environment is going to take $11 an hour, which is where we start off our DSAs, and come into a facility where they're going to be mandated double shifts every day, and you don't know when you're coming if you're going to be mandated because somebody calls out. Or maybe you do know the day before and you make the decision, I'm not doing that one more day. I mean, but you're not going to come in and do that when you can go and work at the Wawa or, you know, in some other industry that's less risk to you. You're not going to be assaulted. You're not going to, you know, potentially, I mean, I guess anybody could be assaulted anytime, but it's not a daily thing. And you're not face-to-face with high-risk patients in a pandemic. They're not going to come and work. But if we can get them, if we can get the compensation where it needs to be, and we can get some out-of-state staffing that will come in and work and get the volume down, so it's not that you have to mandate. You can consolidate your units, so you don't have maybe 10 units. Maybe you have 8, and those other 2 unit staff can go and help and support and make it better and safer on those other units. Then you can open back up to admissions. But we got to fix the staffing, and we got to fix the safety. And I'm not talking about, again, that we have to be perfect in our staffing for us to reopen, but it's got to get safer. And we're working really hard on those discharges, and that's what I've asked our CSBs to do, is that they have staff that are working on this. But they also, many times, are wearing 3 or 4 different hats. I need them on the line working on discharge planning. So we can do it in a matter of weeks. It's not, it doesn't have to be months.
Chairman?
That's what I'm asking for.
Mr. Chairman? Yeah, thank you. So I hear all of that. I guess what I'm trying to see is, in being solutions oriented and trying to think about that, so more money would attract new people, and then the new people would help alleviate the reason why the old people left?
Right.
Okay.
So
I
if
just
we
want-
don't, if we
I'm
get
trying to
more
connect
people, we don't
dots.
have to mandate the overtime to fill the slots
Got
that
it.
are empty. That's why we're doing this, because you have to have staff. And so the only way you can do it, when the number gets lower and you still have this much to do, you have to mandate the overtime. So we need to be able to attract, we need to be able to contract to support them as well. So there's less mandated overtime and things get safer.
And I assume, Mr. Chairman, I assume that is coming in a slide on what
Yes,
that,
yeah,
okay,
yes,
thank you.
ma'am. Yeah, yeah.
I do, but it's not immediately on point, and Sarah's going to put something up
Okay.
from your April presentation. I just want to talk about it. I can wait, in other words.
Sure.
Then,
Okay, but we can do,
Commissioner
next
Lamb.
slide, please. So that was actually, I was going to pause before I did my ARPA request and see if there were any other questions, but since we've been answering them, maybe we'll move forward. We've been asking and answering. So next slide, please. So we really had 4 areas of focus that we put together for our ARPA request, and we really do believe that our requests do align well with the ARPA purpose and allowable activities. So you'll see some of those in bold there, some of the stated uses of funds that are in the ARPA are to support public health expenditures, public health and safety of staff, safety staff, providing that premium pay for essential workers. And those are really offering, that additional support to those who bear the greatest health risk. And ours do a twofold risk, not just a COVID risk, but these are high-risk behavioral patients. And we're seeing, again, all of the injuries and things that are happening. So that seems to really make a difference. And then that optimization of business process improvement areas, especially in IT and data management, so you'll see some requests in there. So our areas are growing in the areas of equity, data, workforce, and quality, so that we're prepared to meet the growing demand for mental health services in the Commonwealth and raise the bar for a more equitable and high-quality system of care, and really making that transformation that I talked about, so you'll see things around that. Second is building community capacity, which is really what our long-term focus needs to be, to have that prevention and wellness more on the front end so patients don't end up in crisis. Third is addressing capital needs and ongoing pandemic-related needs to make sure we have the infrastructure to treat patients in a therapeutic environment and prevent the spread of COVID-19. And then finally, and most urgently, as we've discussed today, several proposals that will help to alleviate the crisis at our state hospital. So that's going to be the ones I'm going to talk about first. Next slide. So, of course, our highest priority request is designed to rebuild our essential workforce, and rebuilding that workforce will assist with increasing safety and security measures to prevent serious injuries to patients and staff while decreasing risks and maintaining safe and therapeutic environments. So these are the ones at the top, the high rated ones. So what I did was I put kind of what we've asked for line item wise, if we will have to have ongoing funding, or if we only do the one time, we would have a structural hold. And then what the priority level is. I know we've had a ton of asks and requests that have come in, both to the administration and I'm sure to y'all. And I think that the agencies, I think they said, I saw a number of 18 billion when there's only 4.3. So I know some things are gonna be, everybody's asking for everything. Not every request will be approved, and so we tried to give a priority, so if we're going to knock some things off that we,
I appreciate what you're doing. We have to do the workforce. We have to do something there.
Yep.
But I want us to also, part of the reason why STEP Virginia hasn't been implemented is it's not been fully funded.
That's another one of our buckets. This is just the state hospital
Well,
ones.
I want to make sure that we're not losing sight of the big picture.
Right, yeah. So that's that rebuilding, the recruitment and retention. This would be the direct care staffing positions and moving them to the 75th percentile, because we are not going to be able to attract at the 50th percentile. We are going to have to, these are high-risk patients, and to attract the staff, we are going to have to move to the 75th percentile. It's also providing critical security and safety infrastructure. Some of that is for capital, that would be one-time capital that would pay for things like duress systems and making sure that our environments are ligature-free so we have fewer suicides and that type of thing, but also for additional security staff. And then also putting in some discharge infrastructures. They are just really, we need to have our community integration efforts need to be double down on. We need to be able to better manage the demand of these increased TDOs and assist with census reduction efforts. And this workforce will be used to expedite discharges and free CSBs to provide services that are needed in the community. That would be a much better use of that staff and to be actually providing services and access to services in the community. We remain committed, of course, to engaging private providers to build out capacity for inpatient psychiatric beds, as well as step-downs for the discharge placements, and expanding community capacity to ensure dementia patients are cared for in settings that are conducive to their support needs. And that's also critical to ensure that we prevent inappropriate state facility admissions and reduce the overall geriatric census in our hospitals. Each of these measures, we feel like, outline a significant step towards ensuring state hospitals remain operational for the immediate and foreseeable future. It is imperative that we take action now, we believe, to address these critical issues.
Mr. Chairman,
Senator Mason.
for the buckets that are high priority, how many people on the extraordinary barriers list today?
Over 200, I think it's 213.
213, Mr. Chairman.
Senator Mason.
So I have not understood. You have been on number 3 since the beginning. You feel like you should take 39 FTE in Richmond and manage discharges across the state, which I don't understand how we think centralizing that makes it better.
It's
or
not
that you
centralizing
have-
it. These would be staff that go into, or at each individual facility and are working on the discharge with the treatment team. We already have people working on the discharge, but we are not able to get the throughput that we need if we rely on folks who are not getting into the process until they are ready for discharge or later once they come to the EBL list. And we need to be working on discharge on day one. And
Mr. Chairman. And we have 2 of them at Eastern State who are largely working with the people that do this every day. I mean, so I don't understand that direction. We have a high degree of forensic population there that are discharged in an average of 52 days versus the system's 83. So already getting those folks in and out more quickly than the average of the system. Why wouldn't we take $3 million and find more places to put people on the extraordinary barriers list who are eligible for discharge with nowhere to go? And it's been between 195 and 215 in the 8 years I've been paying attention to this. We've made no dent on that. So why wouldn't we take that money and find more homes for people that could be safely discharged?
we could do that, but we also could improve the operations at our facilities to be in support of operations for short-term acute patients instead of the way that we have been built this system and designed this system, which is for long-term chronic patients. And I've said it before, our system is designed perfectly for the outcome we're getting. We need to update our operations. We need to have the throughput. We need to have patients that should, and in any other civil TDO patients that are in any other psychiatric facility would be out in significantly lower lengths of stay. We could have patients, the majority, 66% of our patients currently are discharging within 30 days. But that population that can be turned in that time could also be turned in 10 days. You see a 5 to 7 day acute stay typically. I'm even saying if they could go in 10 days, what a difference that would make. But we can't do that with the way it's currently set up and designed. We need to take responsibility for starting on the day of discharge, developing a great discharge plan, assessing the needs, including the family, including their providers, their case managers. We need to be getting the MCOs that many of these patients, they have case managers. They're funded to do case management and care coordination to also help on getting this done. We can't stay doing it the same way because we're going to get the same result. We need to just bring these efforts, up to what we've become. I mean, we now have 2/3 of our patients are not long-term chronic, and we need to change our operations and our design and our system to address that.
Are you finished, Delegate Watts?
Thank you. I always feel it's at such a disadvantage because I don't have the same intimate relationship with our major hospitals that other panel members do. But when you are talking on this point, I do have Northern Virginia facility, and over the decades that I have visited it, I know initially I was a little taken back at how quickly, how short a time people spent in that facility. And I noticed that it's still open and does not have the turnover. Do they represent the model that you're talking about in therapeutic treatment? Are these people safely turning over?
Yes.
There are obviously always incidents, but I don't have a long list of any problems in the community. Could you speak to what is happening? Is this what you're talking about?
Yeah, this is what I'm talking about. And I've operated facilities, we're going on 25 years now. And so I have never seen a system where somebody who is not the treating physician and the treatment team is able to determine and even override the clinical judgment of a physician that their patient's ready for discharge and that the discharge plan that the clinician and the provider has put together on that team is not adequate. We're not talking about a shoddy discharge planning. We're talking about a great discharge plan, but we just are able to deliver it faster. We need to deliver it faster so we get that throughput. We have the beds come open so the patients that really need the care that are sitting in the EDs can come in. We keep people after they're ready for discharge locked in a psychiatric facility that's understaffed, underfunded, and that's a human rights violation to me. We should not be keeping these patients past the absolute time that they're ready for discharge.
Mr. Chairman,
Delegate Watts.
perhaps at a future meeting, I would appreciate a presentation on the program in Northern Virginia so that we can try to understand what actually is the average patient stay, what's the range of it, and to what are they discharged? What is that coordination? Does it, I don't know the details, and I think we could help.
I think that's a good idea, and I would suggest that the new commission, once because we're reconstituted, we're going to have new members, that we re-engage, we'll have another tour basically of the system so that we can all become familiar with the hospitals we have.
But I also would like the stats, you know me.
I know this.
It's not just what it feels like on the ward. I really want to know what over the years has been the relationships established.
And that's important. I think it's useful also to talk to people that work at the hospitals, which we were able to do before.
Okay, great. I would welcome y'all to come to any of our facilities. Yeah, and see it for yourself. Next slide is for the community capacity.
I have one more question about this first slide, and I apologize. Under a medium priority, you've got $4.5 million going to CCCA, and it says that you anticipate full billing by December 2021. Does that mean you're going to be back up to 48 beds there?
No, that means, well, if we have staffing, we will, yes.
Okay.
That means we stopped billing when we found out that we were certified incorrectly, if you'll remember. So we had to, self-report.
Well, has that accreditation issue been taken care
So
of?
we're hopeful that we will be fully through that by that December 21st thing. So we're still working on it, but we still have several months before the site visit by Joint Commission.
Okay, thank you.
Yeah.
Mr. Chairman, this is
Delegate
Delegate
Ranson, sure.
Hi.
Sorry, I'm joining by Zoom today. I apologize, I'm not there in person. I had a quick question and comment on the previous slide. I think we just jumped real quick. And the questions, Commissioner Land. A lot of what we've been working on in Chairman Mason's subcommittee is the ECO TDO very serious issue with law enforcement and our patients that come into the emergency room. We thought in the beginning they were sitting there without getting immediate treatment for 48 hours. The last case that I received in my office was for 7 days. 7 days, I had a woman sit in the emergency room. So I just want to stress to the commission members that we've got to focus our attention on making sure that these hospitals, whether it's the private hospitals and the healthcare there, or Commissioner Land is focusing her attention on making sure the patient is getting the help that they need. She talked about aggressive behavior, but whether they're aggressive or they have psychiatric needs or they have physical needs, we have to make sure that they're getting the help immediately. We're leaving law enforcement at their bedside. And what we're not doing is getting them any type of psychiatric care. And this has been going on for years. So what I heard Commissioner Land say is that she's going to sign a contract on August the 1st to help alleviate the hospitals that are closed. And that's going to get her through for 13 weeks. So what I'm hearing, maybe the end of October. What are these funds going to do? When are these funds? When is she hoping to get these funds?
The staffing we're doing out of our reserve funds. If we're having an emergency now, I'm spending it. I'm going to totally deplete it towards this effort, both for the contract staff that you mentioned, as well as the bonuses that I hope will encourage our staff to stay and understand that we have listened and heard them and are going to do something real this time for them. And so I'm hopeful that will help as well. And I have done I have sent out contracts that could help these hospitals that are having these patients, whether they're boarding in their ED or they're actually admitting them to a medical floor or to a behavioral health unit. If they have, not all of them have them, but to say I'm able to help. I've got some lipos or DAP dollars or something that we can use to help you until it's exhausted. But we want our patients to get the treatment. We want the patients to get the treatment. And if they were a heart attack patient or a stroke patient or a trauma patient, those EDs would have the resources on hand to meet the demand. They know they have thousands and thousands of ER patients in each of these facilities that have psychiatric issues. And if they are not able or willing to provide the care, then I believe that that's, in fact, an EMTALA violation, because a psychiatric emergency is a medical emergency, and they are required to screen for that and to provide stabilizing treatment. And so if they're not, we have a problem. I know a lot of them are, but some are not, and we have a problem in those cases. That would be my response. Okay. So next slide is about the community capacity. And so, of course, it's impossible to discuss proposals or requests to help our census crisis without, also saying what we really need to do is to make sure we have the community capacity to keep people from going into crisis and ending up in an inpatient, whether that's a private or a state inpatient psych facility. So what we are continuing to work towards is to develop a comprehensive continuum of services that meet the mental health, substance use, and developmental services needs of Virginians. And we're trying to do it, of course, in that least restrictive, so staying out of the inpatient acute area. So we're hoping that we could accelerate the remaining steps of STEP Virginia. So you'll see that we have listed to complete that final planning and implementation of the last 3 steps, which are care coordination, case management, and psychiatric rehabilitation. We are also asking that we could do the build-out of the crisis system under the Crisis Now model and accelerate that instead of into the next biennium, going ahead and doing that second round of the crisis services. So that plan hopefully will be a game changer for us if we can do that.
Let me understand that if I can, Commissioner Mann. The crisis receiving centers would kind of replace the emergency room, is that the idea?
Right, so the crisis receiving centers are really, it's a comprehensive center, so it has not only the CTAC, which is really that drop-off, whether that's by law enforcement and transfer of custody, or even a walk-in could come into the center. Then they would be assessed, if they needed an inpatient level of care, they could actually have the staff there that would do the medical clearance, so the nursing and physician staffing to do it, whether that was, if you were going to go to a CSU or an inpatient, they all require a medical clearance to make sure that it's safe to accept a patient. So that could be done there. They also would have an opportunity for some of our patients who can stabilize in 23 hours or less, or up to 72 hours, to be able to have observation services there, so a 23-hour observation services. And then also within the center, we would have crisis stabilization units, just like we have today. And so we would have, that would be the build out, that's what we're talking about. But we also have the mobile crisis, so we have the call center, and we found when we've gone and talked to different states that about 80% of the crisis calls can be resolved over the telephone. And so a lot of the calls that people get now could be resolved, and referrals to treatment and things like that done so that they can not need to be taken to the emergency department,
So you think you could do that statewide for $20 million?
So the request that we have and what we're trying to do is take what we've currently got and build them out so they already have bricks and mortar. So if you have a CSU, is there a way that we can just add on the CTAC and the observation, the 23-hour observation to them? And so we've identified which of those, and we've put them in here. So that would be the method that we would talk about, is making what we've already invested in more comprehensive and better, so we get a better result.
Okay.
Yeah. The other piece that I failed to mention is that if we get a crisis call to the call center and they need to have a mobile response, our team would go out to the patient and would do an intervention there, whether it was therapeutic intervention, or if they needed to, we would be able to take them to the CRC, the Crisis Receiving Center. And the Crisis Receiving Center, if they do need to be transported to a different level of care or a different facility, our folks would do the transport instead of law enforcement.
It seems to me that could be a game changer, especially if it's accompanied with some legislation that does transfer custody.
Yes, sir. That's what we're hopeful for. Let me just see. So that's that slide. Next slide, we have some other community capacity requests. And these, of course, those on the front page we think are the highest priority. But we do have additional requests that we believe would accelerate building out STEP Virginia, and also supporting these initiatives needed to ensure a successful and equitable implementation of these steps. So we have 5 additional one-time funding requests that support the implementation, and these are proposals focusing on aspects of behavioral health enhancement, the Marcus Alert implementation funding, and community well-being projects to improve population health outcomes. The Equity at Intercept Zero initiative, which was developed through that Marcus Alert stakeholder group, would allow for additional support to small private providers, particularly those already underrepresented in the behavioral health care system, to remain viable and increase in number. We've also prioritized replacing the data and financial information exchange between DBHDS and the CSBs with block grant funds that are also in ARPA. And then also we had that JLARC report back in 2019 on CSB funding, And not only did they say that the infrastructure poses a risk, but the structure of the funding itself was recommended to be updating. And so we're hoping to achieve true transformation there and are proposing to use ARPA funds to allow for a shift to reimbursement-based structures for CSB funding. And then as we've been working on the Marcus Alert, and we've done our statewide plan, and we're looking, and the local areas are putting together their local plans, we've seen that there are cost and activities for the 911 centers have been really significant. So we believe that if we could offer some planning grants and one-time funding to those localities so that they could launch their local Marcus Alert infrastructure, that would ensure the success of the project more fully. So we thought that was a good one to support those localities.
Mr. Chairman, why do you have that one as low priority?
I believe that others are probably going to ask for that. And so I was thinking I would do high. I mean, we're going to do Marcus Alert, and there are funds, but we think this would be helpful. But I don't think that if it's something that you're going to knock off the list, that would be less priority than the higher ones that are filling out the STEP Virginia. I think we can get more out of the mobile crisis funding that we asked for.
The answer to that is basically you were putting high priority on things that you didn't think
Only
the
I would be
legislature
asking for.
would be doing itself. You
Yeah.
want the governor to ask. Well, let me ask, is this going to be part of the governor's proposal, or?
So
just what
all
you've
of these
asked?
funding all of the agencies put forward their requests. These are the requests we put forward. We have not been told what he's going to support.
Okay.
Yeah, so, but this is everything that we asked for. And so we did, and I assumed that there would be other stakeholders or agencies that these might be their highest priority, some of these. And so I put ours lower because I think that probably my high ones are not going to be on the list of other agencies. So just trying to get as much for the system as we can, I guess was what I would say. So next slide. We also had within ARPA and within the Consolidated Appropriations Act, 2 sets of supplemental block grant funding down to the state. And so you can see on the left-hand side is the CAA, and then the ARPA's on the right. And so we had to submit plans to SAMHSA for both the mental health funds, what our plans for the funds were for mental health and for the substance abuse prevention and treatment. And so we turned in the first one and were approved. Our plan was approved. We had to submit by July 2nd, which we know that y'all actually get to approve it. But if we were going to get it at all, we were going to give up the opportunity if we didn't submit a plan. So we did submit a plan on July 2nd. And so we have not received the approval of it, but it's in the process. And so you can see there what the amounts were in each and when the dollars become available. And one thing I did want to point out is that the spending that's allowable under the block grant is in line with what currently existing block grants have to do. So there are very specific things. And so I was going to share a little bit about that. So there are a number of required set-asides of the block grant funding, including a minimum of 20% must be spent for primary substance use prevention, 10% for first episode psychosis, $4 million for pregnant and parenting women, a portion for children with serious emotional disturbances, and a 5% set aside for crisis. The general aim of these funds is one-time infrastructure and core services, so treatment, and also funding to support the comprehensive community system that we're putting in place here and enabling Virginians to function specifically outside of inpatient settings. And so you cannot use these monies for inpatient activity. We did do some census-related things that can help with our census as part of this. We proposed in the CAA funding for detox beds, 23-hour observation, and enhancements to crisis intervention team assessment centers, those CTACs, as well as crisis stabilization units and mobile crisis. So we are going to be able to use that. We just can't do it at the facilities. And then in ARPA, we also had some census-related initiatives, and we have over $5 million, which will allow for the implementation of an evidence-based model of case management and discharge planning, as well as building in peer bridger supports and integrating with permanent supportive housing programs. And that would include putting 10 case managers to work in the community that are focused on hospital discharges and making sure that transition care once they leave the hospital is successful and endearing, and that they are getting to their appointments, their follow-up appointments, they are getting their medications filled, all of those types of things, and really focusing on that transition between the hospital and the community. We also asked for funds in the plan to include infrastructure for school-based services, as well as intensive care coordination for youth that are at risk for hospitalization, suicide prevention, and adverse childhood events prevention, and expanding those programs. So that ACEs program, for instance. Next slide. I'm sorry, it's very detailed, all of these things. Actually, I think it's our last slide, so y'all will be relieved that I'll stop talking. So we did have some proposals for equity, data, and quality. The pandemic did reveal deficient IT systems in state agencies nationwide that were unable to meet the demands of the crisis. And for DBHDS, these are decades-old challenges in our system. We are currently in the home stretch of exiting the DOJ settlement agreement, but a big hurdle is the integrity and validity of the data that we are able to provide to support required outcomes on the compliance indicators and ongoing monitoring as we exit the DOJ settlement agreement. This is a direct result of dependency on out-of-date technology and collecting data from systems that were never designed for what they're currently being asked to provide. And our biggest challenge is with programs delivered through CSBs and private providers. Critical information is reported in various IT systems through Excel spreadsheets and Access databases with hand entry and only gives a small snapshot of changing scenarios. The capability exists for these systems to share information, but significant work is needed to standardize and create interfaces. This will solve multiple challenges with the settlement agreement and make patient management more efficient and effective as we can get that longitudinal view of the patient across all of the elements of the system so that we can make sure that we're coordinating care and that people are staying on their treatment plans and their discharge plans. Virginia is investing millions of dollars to transform community behavioral health programs. Major improvement in IT infrastructure and data reporting is also needed to effectively manage these programs and to understand the impact of these programs and if we're actually getting better outcomes. Expanding community programs through initiatives like DOJ, STEP Virginia, and Bravo has resulted in a large increase of private providers that need to be licensed and monitored by DBHDS. Most of this work requires in-person visits statewide. I mean, it's all across the state with substantial reporting of compliance and corrective action. Staffing for licensing and human rights is insufficient for the current demand, much less the future demand from expanded community services. And so during the pandemic and going up to when those new services came online in July 1st, we have seen thousands of new requests for licensing. So but we have it takes so long to do the full application and get them in. We need to be getting these people online faster. And so, we have a real need there. And then we also did, in the last year, hire a new diversity, equity, inclusion officer. Dr. Tanika Mobley has joined DBHDS, and it's a good start, but we do not have additional resources available for additional staff or to develop and execute the training programs to achieve strategic priority and become really proactive within our agency and making sure that these DEI initiatives are endemic in the DBHDS culture. We have a lot of work to do, and so we're hopeful that we have support for that as well.
Thank you. I think Delegate Watts, then Delegate Price, and then Delegate Bell had a question from long ago.
Sure.
Okay. And my question is back on slide 11. On slide 14, you have those that are one-time and could fall under the ARPA, the rescue funds. Can, on slide 11, any part of the crisis receiving centers build up be under one-time ARPA?
That's what we feel like that is appropriate, because it's really going to be,
So you would also identify that one. Is there any other one that I've missed that could be ARPA?
So I think our impression is that each of these would fall in there, because it does improve.
Well, I was going more to the budget concerns of one-time
Right.
versus
Oh,
ongoing.
yes, in that middle.
And this has a one-time build-out to
Yeah.
build some of
Right.
these centers.
Right. So in that future FY fiscal years, we have what each one of those is. So ongoing need in fiscal year FY '23 and into the future of the same amount annually. And then we have carry forward on the final step planning.
I understand
Each of
that.
those, yeah.
Sorry to cut across, I know time's short. What I want is the identification of what is an initial investment to get some of these facilities expanded that we could isolate under ARPA funds.
Assume that you don't have ongoing funds, because we're not getting another ARPA.
Right.
That's why
Yeah.
one-time funding is going to be the priority.
Yeah. So I think that what we have said to, and when we sent up our request, they asked if we could use this as one time, but what was the ongoing need? And that's what we've got. So most of this will have ongoing need.
Thank you.
Delegate Price.
Yeah, so my question, Mr. Chairman, is along the same lines, because I just philosophically am a little nervous about putting one-time funds into something that's going to have ongoing need without knowing what the infrastructure looks like for increased revenue in order to sustain the ongoing need. But I also understand that the first half of your presentation was about an urgent situation. And so I understand this is a long list of priorities, but much like Delegate Watts, what can satisfy the few eligibility requirements of ARPA funding, but can get to the most urgent need for the hiring? Because I see the 75 million recruitment. So you have your emergency funding that you're using for bonuses, trying to keep the people that you have stop the bleeding, and then the recruitment brings on, but you're bringing on people for ongoing employment, hopefully. So how do you see August 2nd versus January conversations?
I would say that we would have to ask for that to be added to our base budget. I mean, we would need that because we would lose all our staff. I mean, if you can't say we're going to align you to a new rate and then not fund for it. I mean, we would have to have ongoing funding.
Right, and I guess, Mr. Chairman, my question is, how do we do that before August 2nd? Because in order to put, I'm sure the two chairmen, the chairwoman and chairman, in order to put something forward, and in order for us to support it for August 2nd, so I think there might need to be some conversation that we have on what ARPA could go for right now as we're building that mechanism and infrastructure for the ongoing funding for future conversations. Definitely understand that the investment has to happen, but I just don't know that what we have in front of us is eligible for what I understood we were doing on August 2nd.
Yeah.
And Delegate Price, I'd have the same concern. Delegate Watts, I have the same concern, but I would anticipate that if the governor's going to put forward a proposal, we'd also put forward the commitment.
That's what I was
The
gonna-
dollars would be in his budget presentation in December.
Yeah, I'm assuming that whatever he supports of this, because we
Right.
did send him up, we don't know, that he would take that in consideration when he's delivering it to you.
And that is a big assumption, as Delegate Price
Yeah,
points out.
yeah, that's what I'm saying.
Delegate Bell.
Ma'am, I asked Sarah to pull up, staff to pull up a slide you had in April. We've had a lot of talk, what I call down in the weeds, about fixing a specific aspect of the problem. But if we're here because of a staffing crisis, and I think you shared that the staffing crisis is itself exacerbated by the population crisis. They feed off each other, and
Right.
okay. And so, we were here, and we've talked about the increased number of TDOs, but they have been going down since 2017. And the total number of TDOs is down from what it was in 2015. And I pulled up, we got a letter from Richard Bonney's shop, and he says, The most immediate and direct cause of the current census crisis at the state hospitals is not an overall increase in the number of TDO patients in Virginia, but a dramatic and continuing drop in the number of those patients that private hospitals are willing to accept. And by his count, it's 19% down. I did just simple math. There's 4,276 fewer private hospital admits from 2015 to 2020. And since the state hospitals have to take them if the private hospitals don't, can you please share with us what is happening in that space? I understand that they are now offering to take a very modest number more. If staff is paid for.
If we pay for the staff.
Sure.
Yeah.
And you have said that you are begging them to take some, but I think it's critical to say it's not that they're taking the same number and the TDOs have gone up. What's happening is they're taking 19% fewer than they were 5 years ago.
Right.
Okay.
But the number of, as you can see, I mean, there's also voluntary patients, and I think they have significant number of beds offline as well due to staffing, workforce shortages. I just think that it's very easy under bed of last resort for them not to accept a certain type of patient that they can just make us take. I mean,
Okay, but in the day-
that's how it's kind of
Mr. Chair.
changed.
Okay, I think that's facile though, because back in the day, they also refused them, they just treated them.
Yeah.
And people died. And that's what sort of prompted us to say we gotta
Yeah.
have a safety
Right.
net under that.
And I agree.
Okay.
Yeah.
What can we do if we have all these reasons why we don't want to or can't increase the number of state hospital beds, and the overall number of TDOs is down? I mean, there's a third option, which would be that private hospitals take just what they used to take. At that point, all of your problems go away. We're not saying you got to take more. We're not saying you have to build more space. We're not saying you have to increase. We're saying just take what you used to take, and all of these things we're talking about are gone.
I don't know that we can make them take it. I don't know how we make them take it. I would be open to suggestions, but I know.
Couldn't we tie Medicaid reimbursement to something? Could we
mean-
use some of those dollars? Don't we have some levers in the payments that we do control to state hospital, private hospitals?
Yeah, well, I mean, I think you do, but they also would prefer, they would be able to say, my beds are full with voluntary patients, because there are voluntary patients that do need treatment too. So I think that's usually been the reason that they say their beds are full.
Well, doesn't that infer that they can manipulate the bed registry? They can say they're full when they're not full.
I don't know that I would say that about them, but I'm saying if you have voluntary and involuntary, we only take involuntary at this point, then they're having to take care of all the voluntary plus whatever else of the involuntary they feel like they can manage. They have a high risk aversion. I mean, I get it. I just feel like that. I don't know how we make them take a patient that they feel they're not going to be able to manage. They're not going to have a physician willing to accept, that is going to potentially injure their staff or other patients and tear their building up, which is a huge cost. I don't know how we make them take it unless we can incentivize them to take it, to harden their units, to spend the money to harden their units, to increase the payment so that they can staff appropriately at a higher staffing level to take the patients. These are all types of things that I've been trying to talk to them about, because frankly, I was willing to help them do that. Do a contract, pay what you put the rate in the blank. And send it back signed, and I didn't get very many back.
Mr. Chair. So on this very issue, so we are told that in other states, we have the highest proportion in the top 5, top 10, various studies, but of state hospital beds available. So in theory, our capacity is sufficient. We also hear that in other states, the hospitals, there's no issue about drop-off points or sitters. I saw something where we're going to pay $3 million just to have somebody sit in an emergency room so that law enforcement can get out. And that's great for law enforcement, but doesn't fix. How do the other states do it?
Yeah.
Hospitals in those states have some of the same issues ours do, and yet somehow they do not have state hospital beds.
Yeah, we have, one of the things I'll say is another thing about this dementia, the dementia care. We have the number of patients times the number of days and length of stay equates to an Eastern State Hospital being full of those patients 24/7, 365. So we could have 302 beds open if we can fix that, if we can build the competency in our current long-term care, assisted living, those types of, supported residential and those types of programs to manage these patients in the community. I know that there are geriatric patients and dementia patients that also have psychiatric crisis and mental disorders that would be appropriate to come to our facilities, but we get all of the primary dementia patients that are, and it's normal for them to have agitation occasionally and have behaviors, but we don't manage it in place and give the supports and services for them to be successfully managed in the community. That's how they end up in the ED, and they can't come back because it's a safety concern, and they end up TDO'd to the state hospital. I know my mother passed away this year from dementia, and had dementia, and she was in a nursing facility who was able in Georgia to manage it. I would not have wanted her to be locked against her will in a state psychiatric facility unnecessarily.
Mr. Chair, I don't want to leave this point. That would be a good idea. That would help us. But every year since 15, I'm just looking right at it, we went from 22.2 to 21.9 to 21.4 to 19.6 to 18.6 to 17, I guess that's 18,000, and projecting 16.7. The private hospitals have reduced the number of admissions they're willing to take under TDOs every single year. We as a state, they have a COPN protection that they say is necessary so that they can provide services. You've got the EMTALA law that you mentioned the other day. I don't know if that would enable you to have some leverage. The state expanded Medicaid, and again, that was at the request of the hospitals, among others, but that was something that happened. Is there no leverage the state has to say, with all of these things that you ask and receive, that you have to at least take what you used to take? Because, as you say, what's happening is they are going to the state hospitals, which are now swamped and having, the staffing issues you've described. But in terms of short-term solutions, everything else seems to be a big or a small Band-Aid when ultimately it's a population issue. But the population issue is being driven not by an increase in TDOs, which seems to be what everybody talks about, but this, at least since 16, a steady decrease in TDOs, I guess 17. Steady decrease in TDOs, but an even faster decrease in beds accepted by the private providers.
I do think that the number on the FY21, we should have updated that to actual, but we had that first quarter of the pandemic with the stay-at-home order before we started reopening. Nobody was going anywhere. So we had a significant drop in census for that. So that may peak back up. I tend to think it's more of a flat instead of a decreasing, but we are definitely getting more of these patients. The percentage of these patients is increasing at our facilities and not staying with theirs. So I would be open to anything that we could do, any lever we could pull to help with, making it possible for them to set those patients or incentivizing them or whatever.
Chair, I'll stop. There's other states, we keep being given the same fixed, without the opposite of variables. We're told we have a lot of state bed spaces. We are told that we have the TDOs are within the parameters other states have, and we have this crisis, and our private hospitals are not taking them when other states are. I don't know what mechanism it is that these other states have the private hospitals take these admissions, but
many of the other states have hospitals that they've closed hospitals and have fewer hospitals, first of all, but some of them only take forensic patients, for instance. They don't do the civil patients. Many of them don't do, they have exclusionary criteria in their code, I guess, for the dementias. They're able to do things that allow them to not take certain patients while still remaining a safety net for the true serious mental illness and, substance use and co-occurring patients. So I think they too have done that, the flip-flop nature of we put most of our money in the acute instead of in the community services. They've done that work and made that transformation and built that community capacity too in these other states. So.
Thank you.
Delegate Watts, and then we're going to have to.
I'd like to follow up on Delegate Bell's line of questioning just to get a perspective. So if I would like to believe that 7-year history also shows the reducing of the stigma of having mental illness and needing treatment. So I need to have where can we get accurate stats on the number of patients in the private mental hospitals so that I know the degree to which that voluntary commitment component has in fact increased so that I really know what their capacity is.
I think that that at least when I was in the private sector, we provided that through VHHA to the commission.
Yeah, and that chart just represented the TDO patients, so
Yeah.
So
Mm-hmm.
involuntary.
I need to have that other then.
Yeah.
Senator
I'm
Hender's
sure.
got a question, and then we're going to.
Thank you, Mr. Chairman. I think I still have a question. Most of my questions have been answered as everybody has been engaging, but I've got a couple of comments and maybe a question.
Sure.
My comments, you're not going to get any direct public criticism from me on the system at this point in time. We're all involved with the management of that system. As Senator Dees pointed out at the beginning, it's time for us to push this thing a little harder and do what we can do. And I would say that the system actually has, I've been surprised that it's been maintained probably as well as it has, given the fact that with COVID, everybody's on edge. Anybody that's prone to mental illness or substance abuse disorder, we're all on the edge of our seats. Some of us up here are a little bit off center right now. And so, you know, it's been difficult to manage. And what I've observed, you know, in other states, they say that they have the same problems. It's just managed in different ways. So what you did last week caused some excitement, but actually it probably helped us out. I think we have political buy-in now, and it's fortunate because we also have the resources to do something about it. We pulled back with our funding for STEP Virginia and some of our other plans that we had to build community capacity because we thought we were going to have a tremendous shortfall. Truth of the matter is we outperformed our projections, and now we have this federal dollars available to us. So I want to share that I do support, even though, you know, most of our federal dollars are going to have to go in one-time expenditures, but I do support the $75 million for basically re-benchmarking of essential workers that we're underpaying. And this is not just confined to state workers or just to behavioral health right now. I mean, we actually are underpaying our state employees, and as the prevailing wages have increased, we're low. We're low, so we're going to have to eat that, and it's going to be more than $75 million in the continuing budget. It's going to be in the hundreds of millions, I suspect, by the time we address all the provider rates that we need to address going forward. So I think we can make a positive out of this if we work with you. It's not our job to micromanage, Mr. Chairman, but I do suggest that we're going to have to spend some time so that we're comfortable, just as Delegate Price indicated. We have to be comfortable so that we can convince our colleagues that this money is needed. And I think that's going to be important long term. The sort of question that I had remaining, and it's been broached a little bit, I really feel like are you negotiating at all with the private hospitals right now?
I am.
Because we do have the money available to pay them, even if we shouldn't have to pay them.
Right.
To get out of this crisis.
Yeah, I'm
shouldn't have to
fully
pay.
doing that, yes.
Yeah.
Yeah, we have a number of contracts, I mean, over 20, and are getting, some providers are really helping us out. And I mean, I'll just do a shout out to UHS because they have been a wonderful partner. Shout out to CHKD. To Riverside is also doing a pilot to work on that substance abuse population. We have some real, you know, Carillion is doing an emergency
They are.
psychiatric center. We have some really good, and sorry anybody I missed, but we have some really good partners, but we have other people who have never, even during the pandemic, when we were willing to help them defer the cost of managing some of those COVID positive patients instead of sending them into our congregate setting and, you know, so that we could remain open, just never responded, never filled it out, never sent it, never even asked or responded. So if we could get them to, at this point, I've sent it again, and if we could really get some help and support, I mean, again, I'm willing to pay, even if I shouldn't have to. But,
And Mr. Chairman, just a quick
Senator.
follow-up. The Marcus Alert in STEP Virginia, are they being coordinated? One of the concerns I had was that, you know, there was redundancy in those efforts.
yeah, we had a huge work group that worked on that with lots of the stakeholders. So I think we had 35 to 40, Mira, of the different law enforcement and other agencies involved in that. So yes, sir, we are.
Okay, thank you, Commissioner Mann. You
Thank
know, I apologize, we're behind the eight ball now. We've got a 2:30 meeting across the hall with the new Behavioral Health Commission, which is basically organizational. We have another item on this agenda And my question is, can we do it now and delay that, or do this after the other meeting? We do it now? So, my understanding is we gotta, and I apologize to the new members of the commission, because this is an ongoing issue we've been dealing with. We got a quorum while Commissioner Lamb was presenting, so we have to take the roll. And then we're gonna have a presentation from, I guess, Senator Mason, Delegate Ranson, who's on the line, who can participate. She can't count toward the quorum, but she can participate. She can vote. And Delegate Sickles online too. But Delegate Sickles, thank you so much. And Delegate Hope is also on that commission, so we'll hear from them after we take the roll.
Delegate Watts.
Present.
Delegate Hope. Here. Delegate Sickles.
Here.
Delegate Price.
Can you hear me?
Yes, sir. Delegate Bell. Here. Delegate Ranson.
Here.
Delegate Rush. Senator Howell. Senator Hanger. Here. Senator Barker. Senator Mason. Here. Senator Deeds.
Here.
Mr. Chair, you have a quorum.
Okay, Senator Mason, you led the group on the emergency custody order, temporary detention order issue. If you want to make a presentation, you have a couple of recommendations, I think.
Yes, sir, Mr. Chairman. Thank you, Mr. Chairman. So this was a working group to address those in the emergency room and largely held by law enforcement, trying to find a bed, as Delegate Ranson mentioned in her question. Those are, to note, the people that are not being received in our state hospitals by the decree on Friday at this point. So you find the recommendations in the document draft before you. Some of them do match up with Commissioner Land's presentation. Number one, in October of last year, they completed a report speaking to the CTACs and the drop-off centers, if you will, and regions that did not have access to them. So recommendation number one for us, and they're not necessarily in 1 through 9 order as far as high, medium, and low, but they do kind of represent the level that we discussed them as a group. This is looking to the CTACs in place. And ones that are working, we do have some that seem to not be taking patients for a variety of reasons, and so maybe additional funding would help them. But this is just expanding CTACs that are in existence and have the ability to expand.
So this would coordinate, I guess, with, well, the $20 million request.
Yes, sir. Slide 11, first suggestion, build out a community crisis system. The question is, she said additional funds, $13.9 million for adult and children MCT, $7 million to improve CTAC crisis center. So there's your 20. This was 13 that was directed just at the CTACs based on the October report. Okay. So those two may not match up directly, but yes, sir, that does coincide directly with hers. Number two is showing a couple of different options that came from that October report as well. That is finding areas that do not have, this is kind of the hybrid. So areas that do not have CTACs, do not have places, and are overly reliant on emergency rooms, we would look to develop regional centers that could serve underserved areas, as well as the hybrid there in option 2 would be also expanding the ones that we have, and at the same time developing and building 5 additional centers. This could also work in concert with some of the hospital systems that are developing these emergency psych facilities currently. And so, as Ms. Stanton had suggested in one of our meetings, some of these monies may not, we've given you the highest amount because some CTACs may say, hey, we aren't able to expand. Whereas the one I have in Williamsburg asked for $360,000, I believe, to expand, and recently DBS was only able to give them about $100,000. So they're ready to go. Some may not be. So this would be the top end number that you would find.
And let me ask, both recommendations 1 and 2 are one-time funding. Is that correct?
Yes, sir. And so the one, yes, sir. Options 1 and 2, but recommendations 1 and 2 are taking advantage of the one-time money.
Okay.
3 is not. 3 is the salary discussion that we just had that Delegate Price and Delegate Watts addressed very well. A thought here. Unlike pick a social services worker, a child welfare worker, we not paying them enough money, right? We know that. We need to increase that and put it in an upcoming budget. In this situation, we're paying the money today, okay? So we're paying our employees, say, $12, $13 an hour, which is why we can't keep them, but we're paying a contract company $30 today. So by expanding and putting, in my estimate, a 40% to like the $18, $19, $20 range for the direct frontline workers, you at Eastern State, which is just one example, you would only increase their cost of employee pay by $120,000 a year, because we are already outlaying the money. So yes, Mr. Chairman, and to Delegate Watts and Price, it will have to be included in the biennium budgets on the future as it is a salary increase, but we're paying dramatically more today to contract workers, contract groups, and you heard Commissioner Land talk about bringing some in from out of state, probably even at a higher level. So it's a bit different than our standard, we need to raise state employees' pay. Okay, that's number 3.
If
Yeah, Delegate Watts.
if I could add at this moment, add to that list that all the overtime that you're paying is also, would be better directed towards increased staff. Same money, better directed.
Yes, ma'am. Absolutely. Recommendation 4 is the discussion that we've been having of, say, going to privates and saying, can you help us? And where are you? I know of one that is going to open 10-bed psych emergency next year. I've asked them, can you make it 20? Can you make it 30? And what would the cost would be? Now, we wouldn't pay brick and mortar money, but that would be one-time startup costs towards private providers. Ms. Wicker presented to us and gave us just some rough top-line costs. I have read in the press that there's an $8.5 million proposal. I don't know whom. I know no details from it. But I know that, and you heard Commissioner Land say today that they have been approached by private providers saying, if you can help seat us. I mean, it should be really important to note here that our CSBs, our regional hospitals are having the exact same resources problems that we're having in our state hospitals. So it doesn't make it go away, but it does look to the private providers and ask them, who is in a position to step up and can we use one-time funding to do so? 5 is just a bit more of that, I would say. And also asking about step down, the goal here, why do we ever send somebody with primary substance abuse to Eastern? Primary dementia to Eastern? Why do we, misdemeanors to Eastern, to our state-run mental facilities? So the game is trying to make sure we take fewer people and only use the state hospitals for people that absolutely need it. But then as we step them down, can we have private providers for outpatient work that help keep them from just cycling back through the system? Just trying to recall what, and 6 is where else can we provide these services? I think the expansion of the CTACs up in 1 and 2, and particularly this 23-hour type of ability to cool down, if you will, that wasn't a specific part of the October report, but you've heard groups talk about it, that just can give us a beat and give us some time to try to see if, in fact, they do need to go to our state-run hospitals. The law enforcement crisis situation is how we got here. I think it's, G4S, thank you. Yeah, some of our local providers are saying they're having a hard time getting them scheduled anyway, but you saw Commissioner Land talk about, I think she had $3.4 million for possible sitter services, so taking that contract and going beyond transportation and maybe just giving law enforcement a break and having them to sit there. And then finally, John Jones from the Sheriff's Association came to us and suggested that they needed additional money to continue. Delegate Ranson's case, the sheriff from Gloucester suggested they had one that was 70 hours, and he did a great job of outlining that's 2 employees for almost a full week. 80 hours, 2 employees, and that is a deputy 8 hours, a deputy 8 hours, a deputy 8 hours for 70 hours. And so it is almost 2 full FTE for full weeks of work, just sitting with someone in a place that's not providing the type of care that they need on the spot. So, Mr. Chairman, I try to buzz through those. Those were the suggestions that came up, and with an attempt to focus on one-time money.
Well, I certainly appreciate the work you all put into this. Are there questions for Delegate Mason or our Senator Mason, Delegate Hope? Our Delegate Ranson's on the line, I think. Delegate Price.
Yes, thank you. And I know that we are thinking about this more globally, but also, again, what can be used in our special session August 2nd. But I just wanted to see if any of the conversation had come up. I'm losing track of which of the meetings I've attended, but there was a suggestion about peer-to-peer for the quote-unquote sitter services. Right. And then I know that we're also having conversations about getting rid of some of the barrier crimes so that more of them can be employed. Right. But did any of that conversation come up about who the alternative quote-unquote sitters could be? Is there another word we could also use than that? Exactly. But just who could the alternative people be as opposed to law enforcement?
Did you want that?
Yes, Mr. Chair, Delegate Price. I think that's sort of conflating two different things in this very narrow context we're talking about right now. When we're talking about what DBHDS is called the sitter, and we may be able to find a better term for that, we're looking at a situation where somebody would need to be able to actually take custody of the person so that law enforcement could then go back about their business. And that's what this is narrowly focused on. One option is the G4S contract, which we currently have in place. That's a contract that the Commonwealth has entered into with a private organization to provide alternative transportation. So when Magistrate Special Justice finds that the person is not going to be dangerous, we can allow this alternative transportation service to do the transportation, keeping law enforcement out of it. It would extend that contract to allow them to also wait with the person. So it's a very narrow context.
Delegate Watts.
Sorry, follow up on that clarification. So can that alternative contract be done without a statutory change? And if it needs it, it can. All right, thank you.
Well, I was going to ask basically the same thing. I mean, it seems to me that even if we're limited to budgetary action, anything in the budget's going to override the statute. So we can put whatever we want in the budget, and then if we have to fix it in January, we fix it in January.
Got it.
So you've got the subcommittee's recommendations. What are your thoughts about this? Delegate Price.
Yes, thank you, Mr. Chairman. We did receive communication from Anna Mendez, and I was wondering before we take any votes if we could open up for comment.
Sure. Ms. Mendez, you want?
Good afternoon. My name is Anna Mendez. I'm the Executive Director of Partner for Mental Health. Anna Mendez, I'm the Executive Director of Partner for Mental Health. It is lovely to see everyone as three-dimensional human beings and not just on a Zoom screen. The ECO-TDO work group recommendations were striking, that with the exception of the crisis receiving centers, none of the proposals are really designed to reduce the incidence of ECO and TDO. This is a significant missed opportunity. The majority of the people that we interact with at Partner for Mental Health who experienced incarceration or hospitalization attempted to access public mental health services, but were unsuccessful in doing so prior to their crisis event. I have heartbreaking stories, absolutely heartbreaking stories that I could share with you about that. In addition to better compensating staff, solving the state hospital census crisis will require two things. The first is holding private hospitals accountable for their increasing number of TDO admissions denials. No other state in the country relies on their public mental health hospital to serve short-term acute patients. This is not an issue on which Virginia wants to be exceptional. We must require private hospitals to provide comprehensive and transparent data regarding each and every admissions denial of a TDO patient. Second, we need to make a robust investment in interventions proven to reduce hospitalization. I don't know if you are aware, but currently the Medicaid reimbursement rates for partial hospitalization, which is an outpatient program, and intensive outpatient services for people with mental health diagnoses are only a fraction of the Medicaid reimbursement rates for the same service in Virginia for people with substance use disorder. This lack of parity is absolutely unacceptable, and we need to change it. In closing, I would like to remind you that every day, over 200 state hospital beds are occupied by people that have been clinically ready for discharge for at least 14 days. In addition to contributing to the census crisis, this is an expensive drain on state resources, promotes poor clinical outcomes, and puts Virginia at risk of a false imprisonment lawsuit or another Olmstead decision. It would be cheaper to rent these people an apartment and staff it 24 hours a day, 7 days a week than what we are currently doing. Thank you very much for your time.
Thank you so much, Ms. Mendez. I think your first point went to the work group's work, and the rest went to the hospital issue, and I agree with you. If we kept people out of crisis, we would solve our hospital problem, and that means we have to invest heavily in the community service boards, or in the community service work. What about these recommendations? On the we're providing comment on the recommendations now, or in general? In general? Okay. Okay. And the people that are online that want to talk? Okay. Okay. Well, we've got these recommendations before us. I guess we need comments. We need to decide whether we're going to adopt them or, there are things we need to do. We're focused right now on what we can do in the special session.
Mr. Chairman.
Delegate Price.
Senator Mason, can you go back through just one more time and tell us what of these recommendations is applicable to August 2nd?
So as far as one-time funding goes, recommendation 1 and 2 could fall into those categories. We have existing CTACs that we could work to expand, all right? And so that would be a one-time infusion of, not necessarily 24 hours in all circumstances, but certainly expanded hours, 23-hour cooling off areas and periods, additional staffing, the security necessary, because remember, a big key there is the handoff from law enforcement, okay? So this is saying to these existing places, what kind of money does it take for you to expand your service? 2 also even builds on that and looks at areas where we do not have help. I don't know Central Virginia very well, but I'm originally from Farmville. They have a CSB that is struggling and is servicing 5-6 areas. They have 6 advertisements in the newspaper today trying to find people to come work there, and no executive director at this point. I don't know if there's a CTAC in that region, or the nearest one may be in Lynchburg or Roanoke. I don't know. It would be an evaluation of areas like that, and then seeding money to establish regional facilities or joint operations or contracts with. And so 1 and 2, most certainly. 3 is funding, but as I said, we're already paying almost that amount anyway. So that, but you would have to acknowledge that would have to be an ongoing budget adjustment. And then 4 as well. 4 is beginning to look to the outside private world and say, what do you have? And what kind, and as I mentioned, I know no details of the $8.5 million proposal on the table, but there is one. And are there other areas? The one that I mentioned, Riverside Behavioral, is going to do 10 beds, emergency psych in March. I've asked them, what does 20, what does 30? That would be a one-time startup type of fee. Everything else, if you read Ms. Mendez's and I should say Mr. Cruiser, Ms. Mendez, and Mr. Creekmore were very, very involved in our efforts, and I thank all of you for your hard work and for your constant help. One that we didn't discuss and Ms. Mendez was adamantly opposed to is, we are having to harden state hospitals that are designed to be restorative. So do we, with the large number of forensic cases that we have, look at already hardened facilities and staff them for forensic TDOs? Ms. Mendez said absolutely not. I mean, because that is, again, more bed, but it may be more bed short-term, but it would be taking a regional jail that might not be utilized and turning it into a forensic, but I just wanted to throw it out there as that would be a one-time startup type fee as well. So we tried to focus on that with, of course, an understanding that the salary in our state hospitals, and I meant to ask the commissioner, I don't know if the salaries include CSBs as well, because our CSBs have positions that have been open for years with no applicants.
Senator Mason, I would say this, we've got a salary issue at the CSBs. There's no question about it, but her figures only included the hospitals.
That's what I thought, but I wanted to say it out loud because we can't, they too are resource constrained. And this week do not have the luxury of closing down their services. They are in the emergency rooms today with the patients that we are not admitting to our state hospitals in the civil manner. For civil
Mr.
cases.
Chairman,
Delegate Watts.
to put a discussion on the floor, I would move that we, in fact, pass all of the recommendations in the, and if I can speak to that context, in the context that everything that can be funded in the special session under ARPA and guidance to the formation of the next biennial budget. Speaking to that thought is that it's always, we're a team, administration and legislature, and it shouldn't be just always reactive. And so our guidance now in this critical area, as the budget is formed, rather than having it implied in any way that we're backing away from the criticality of these other recommendations, I think are important that the administration have that. Obviously, before the actual session, after we get the budget, action will be different. But I don't want to not at this point say loud and clear that these are important priorities.
Well, I'm not sure how the process is going to work, but I would anticipate we're going to be able to introduce amendments to whatever budget the governor is going to propose.
There's an ongoing conversation about that.
Mm-hmm.
Some people would like to keep it behind closed doors and be done the first day, but yeah, I think we'll have a more open process.
Well, again, even if we don't do it in the special session, I'm sorry, Mr. Chairman, even if we don't do it in the special session, the biennial budget is being formed. And rather than being reactive to what the governor puts in the budget, I'd like to, in this area, push them as far as we possibly can to recognize the longstanding needs here.
Mr. Chairman, I would second that motion. And actually, I was thinking about adding a number 10, although it's maybe not directly related to Senator Mason's work, but I think we should establish a work group to help the commissioner in transitioning dementia patients out of the psychiatric hospitals into appropriate community-based services.
I think that's a good idea. And even if it's not part of Senator Mason's recommendations, we're going to be in a position to stick that in the budget. I think that's a good idea. We might need to add one or two more work groups too to get some things right there.
Mr. Chairman.
Delegate Ranson.
I'm sorry, it's Delegate Ranson. I'm participating virtually. I want to highlight number 9, where the sheriffs, they have requested funding to the localities for overtime pay. I don't want us to forget that they are the ones in the emergency room with the patient sitting anywhere from 2 to 7 days while they are in crisis. They are one-on-one with them, offering assistance and a guidance while we're trying to find the bed in some sort of capacity. And many times it's 1, 2, and 3 different counties involved trying to navigate their schedules and their calendars. So I hope that we don't forget them. And we're hearing about staffing shortages within the hospitals. Let's not forget that they are also undergoing a lot of staffing shortages as well.
I understand. Thank you, Delegate Ranson. Delegate Price.
Yes, thank you. And I am inclined to support this as well, but I would like to add an addendum to continue the conversation with some of the feedback that we're hearing about the investments that are needed in prevention. I know that we need to act on some things on August 2nd, but I'm hoping that the conversation will stay open before we get to January.
And I hope it'll stay open before August, too. We've got a lot of work to do. This is a process. It's not, we don't reach the end, even at the end of a session. It's a process. Are there any additional comments? Okay, we've got a recommendation. Do we need a roll call, or we've got a motion? Do we need a roll call, or just can we voice vote? Okay, all in favor, say aye. Aye. Any opposed? Okay, the motion. Aye. Thank you very much, Delegate Sickles. The motion passes. The recommendation is agreed to.
Happy to help.
Now, this was the last meeting of this joint subcommittee by itself. As the chair of this joint subcommittee, I thank you all so much for participating.
Does he have general comment?
Oh, we've got general comment. That's right. I apologize. Got some public comment.
Any member of the public that would like to speak, if you could please raise your hand electronically. I will bring you into the room. Mr. Chair, we have Bruce Cruiser.
Mr. Cruiser, you've got 3 minutes.
Mr. Cruiser, if you could go ahead.
Yes, thank you. Yes, Senator Deeds and members of the committee, thank you. I won't keep you, two main points, or really three. The first being, thank you for this hard work that you're doing. This is one of those times that takes all of us to give our full attention and priority. So I really appreciate the attention you're giving to this. But the two main points are just as you deliberate through all this, is to keep two kind of overall values in mind that we would encourage you to have as you make these decisions. And one is, again, safety of the individuals in crisis or patients and staff has to be priority. And I know that will help guide your deliberations and your decisions. And the second one is, it's because we've never built a full continuum of care in the community that we've really muddled the mission of our state hospitals. Let's have them do what only they can do. Use our state hospitals more for longer term care, and then flip this 2/3, as the commissioner said, 2/3 of their people being short-term patients. That needs to be flipped around to at least 2/3 longer term, and the rest in the community. So thank you. I appreciate, again, the opportunity to comment.
Thank you, sir.
We have Patrick Halpern.
Mr. Halpern, you have 3 minutes. Mr. Halpern?
Yes, sir. Good afternoon, Chairman Deeds and esteemed members of the commission. My name is Patrick Halpern, and I am the president of the Virginia CIT Coalition. I want to thank you for giving me an opportunity to address the commission today. With all due respect to Commissioner Land, I would like to correct the record regarding statements that were made about the operation of CSBs presently. Senator Mason posed the question, what guidance are you providing to CSBs following the closure of 5 state hospitals? The commissioner stated, and I paraphrase, the CSBs are mostly operating virtually and do not see many individuals in person or in residential settings. This statement is misinformed at best. The department, going back as far as March, has encouraged CSB emergency services programs to resume face-to-face assessments, and that is exactly what most, if not all, CSBs are doing presently. I can tell the commission today that the CSB operated crisis stabilization units, most of which are TDO capable, have been providing residential care throughout the pandemic. In residential settings throughout the pandemic, CSBs are operating these facilities with the same workforce challenges that are and are subjecting staff to the same unsafe situation as the department's hospital system. CSBs and law enforcement across the Commonwealth face the same workforce shortages as the department, and it is the CSB and law enforcement that are absorbing and managing the enormous risk to the community and individual welfare across the Commonwealth that has resulted from the delayed admission process and now the closure of 5 state hospitals. Despite the fact that we all share the same workforce challenges, I cannot imagine a situation where it would be acceptable if a CSB or law enforcement agency were to shirk its code-mandated responsibility as a result. From my perspective, supporting the request from DBHDS for significant crisis receiving center funding would allow us to meet the critical staffing and infrastructure needs of these crucial community-based facilities and programs, which will reduce the need for inpatient hospital beds. Thank you all for your service to the Commonwealth and for your attention to and concern about the current crisis impacting all communities.
Thank you so much. Who's next?
Jennifer Faison.
Ms. Faison, are you there?
I am. Good afternoon, Mr. Chairman and members of the committee. Jennifer Faison, the Executive Director of the Virginia Association of Community Services Boards. And I will be brief in my remarks. I think most of the things that I would have said today have been touched on, but I would like to underline for members of the committee that we as an association do have a very robust request for the use of ARPA funds, and we have targeted that to the recognition that those funds are one-time or short-term. And when you see our proposal, you will note that many of the things overlap with some of the things that you've talked about today, and certainly would intersect nicely with the recommendations from the law enforcement TDO work group. So I would welcome your questions on the proposal and encouraged by the dialogue today. I would also add that we are, in fact, having the exact same workforce challenges that the entire behavioral health services community is experiencing in the CSB system. And I would add to that, there's another line of business, if you will, and that's our population of folks with developmental disabilities, many of whom do end up in state hospital settings, but they are being served in the community with workforce challenges as well. So the direct support professionals in our group homes and staff who support individuals with developmental disabilities who do not intersect with the behavioral health community system are also, those staff are also experiencing shortages. And, I do want to say that Bruce, I think, is on the right track. The state has a decision to make about the role of its state hospitals and whether they are best suited to serve as acute care facilities or whether they are better suited to receive and care for individuals who may need longer term stays, such as the role in the state hospital system was in the past. And so there's no value judgment there. It's just something that I think is important to get straight, because we can't solve the problem unless we understand kind of the nature of the infrastructure and system that's supporting it. And the last thing I will say is that there is a work group right now that is talking about the discharge planning process, which is one of the things that was also brought up in terms of potential use for ARPA funding. And that work group will come forward with a set of recommendations, and the transition from having discharge planners be in the community and situated with the community services boards, transitioning them into the state hospitals doesn't solve the issue of the main reason why folks remain on the extraordinary barriers list, and that's a lack of community housing. So it doesn't matter where the position sits, changing that is not going to build houses. It's not going to open up assisted living and nursing home beds. So I just would like to put that out there for the committee. Thank you very much.
Thank you so much.
Mr. Chair, the final speaker is Heather Zell.
Ms. Zell, you've got 3 minutes. Are you there?
Yes, I'm here. Thank you very much, Mr. Chairman and members. Good afternoon. As was mentioned, I think we submitted written comments, and so I just want to take a couple minutes to underscore a couple points from those. Several of our points were already echoed in the conversation or by some of the other speakers. So we want to underscore again, that idea that the sort of shorthand of bed crisis, it's not about the number of beds in quantity. It is about where individuals are being placed and the distribution that's really become imbalanced due to the shifting in responsibilities and roles among the different actors in the interrelated mental health system. And so in particular, I wanted to speak just briefly to item 5 and item 6 of the list of recommendations, and underscore for item 5 around challenging patients, in particular, those patients with complex medical needs, and just the unconscionability of, having individuals with complex medical needs being hospitalized, having to be hospitalized by the state hospitals, which are not designed, equipped, or staffed to treat complex medical needs. So this responsibility really just does not align at all. And so we encourage not just incentivizing private hospitals to take on such challenging cases. That's not enough. There should be, I think Commissioner Land mentioned that other hospital or other states, for example, might have exclusions or a reasonable ability for the state hospital to say, we cannot take this individual. So allowing the state hospitals to decline such patients that they are simply not equipped or staffed to care for would be something to consider, and also perhaps extending the ECO period for such patients, since they may take more than 8 hours to coordinate the both psychiatric and medical inpatient care. For item 6 and the role of state hospitals, and perhaps there's, I was realizing while listening that perhaps there's a difference in use of the term forensic patients, but along the lines of what Mr. Cruiser noted as well, that the traditional roles for state hospitals in most states have been for those longer term individuals, but then also forensic services as well. And that's where they have a history of working with those individuals. And so the idea of reducing the impact of the forensic population sort of seems to flip the priority order, or what you might expect in terms of having TDO acute patients be superseding forensic patients. And also just the idea of establishing designated facilities, which would essentially be building beds in one form or another, again, doesn't really get at what is needed if our root cause isn't about the number of beds. And so finally, I do want to, of course, note though that there is room for changes in the forensic populations, but they're unrelated to sort of the interactions with the acute admissions. Has more to do with individuals under competence to stand trial, needing evaluation or restoration, but not needing hospital care, but being hospitalized. And so there's places to make changes there for certain. But the idea of sort of they're taking the beds that we need for TDOs doesn't quite align. So those were the 2 points that I wanted to speak to. Thank you.
Thank you, Dr. Zell.
Mr. Chair, that completes the public
Okay.
speaking.
Before what I was trying to say is that at the request of this chair, I'm requesting the members of this commission meet jointly with the other, and so people who didn't, Delegate Sickles, I hope you're listening to me. People that didn't make the cut on the new Behavioral Health Commission can still get their per diem if they choose to continue to participate. So I would hope that those people are listening. All the members of the SJ 47 subcommittee who choose to continue to participate will still be able to come to the Behavioral Health Commission meetings through the end of the year, and I hope that's what happens. With that, give us about 5 minutes and we'll reconvene across the hall.